Member Senator Wyden for holding this hearing and for bringing some focus on this issue. It was mentioned that the Comprehensive Addiction Recovery Act, CARA, was reported out of the Judiciary Committee by a unanimous vote last week. That doesn't happen around here. And it did so because, one, it's bipartisan. We've worked on it for several years. We brought in all the experts to make sure that it actually addresses the problem, but also because all of us see this epidemic growing in our states, and we see the human toll. And I've been all around our state. I've met with dozens of recovering addicts, some of whom, by the way, are on Medicare. And this is an issue that, of course, we ought to be addressing. So this broader bill called CARA does deal, as Senator Wyden talked about, with prevention, treatment, recovery, which is incredibly important, enforcement. But this legislation that Senator Toomey has proposed is really important because it says, with regard to Medicare, let's be sure that we are not allowing people to do the kind of pharmacy shopping and doctor shopping that leads to abuse. And so I thank you for your testimony this morning and talking about that. I do think that this frequent abuser program also is going to help with regard to identifying people who need treatment. So Senator Wyden's question to you was, is treatment also important? Of course it is. In fact, this very legislation will help people get into treatment because once they're identified as a frequent abuser, they actually are given the information and a referral to treatment. So we need to be sure we're doing all of this, and it's incredibly important. And I thank all my colleagues for joining in this effort, and Senator Hatch for being an original co-sponsor of the CARA bill, and I'm proud to be with Senator Toomey and Senator Brown and others on this legislation. My Attorney General back home, Mike DeWine, has submitted a letter for the record today that I've asked unanimous consent to be included supporting this legislation. He's in the front lines back there at home, and his point is very simple. This is a strong tool to reduce doctor and pharmacy shopping. But also we have the National Governors Association recently talked about this legislation. They support it. The administration supports it. So I'd hope this is one that we could move, and perhaps we can move it along with the CARA legislation. We have seen in our Medicaid program in Ohio, through this lock-in program, a 41% decrease in dosages, reductions in dosages for certain narcotics. So it works in Medicaid, and it certainly should be in the Medicare program as well. In your testimony, Mr. Kukul, you talk a lot about this legislation and the fact that it provides a balance. There are some people who have said, well, gosh, how can I be sure I get the drugs that I need? Can you briefly tell us how does it allow beneficiaries to still have choice in terms of the drugs that they need?
Yeah, thank you for your question, and thank you for your leadership as well on this bill. The legislation requires patient input into the selection of both the pharmacy and the physician that would be the provider. And so they would be able to get those drugs from the provider, and the provider would ensure that they have adequate pain control. So that's the essence of the legislation. Allows the individual to appeal if they think that they shouldn't be in the program. It allows them to change pharmacies down the road if they need to. So there are a number of provisions built in here that help ensure that the patient gets the drugs they need.
Well, thank you. Thanks for talking about that appeals process. I think that's important. This today, we're talking about a lock-in program. I'd like to ask your advice as a pharmacist now. Another topic. It's about lock-out rather than lock-in. Before me here is a pill bottle. It has an inexpensive plastic lock on it. It costs about $1, I'm told. Now think about this. This costs about $1. I'm told that the kind of pills that might be inside of this, if they are opioids, might have a street value of $80 a pill. Do you think this would make sense for pharmacies to offer this as an option? This would allow those seniors we're talking about, if they do need opioids, and they are going to this one pharmacy and one prescriber, and it is appropriate to protect their pills from their grandchildren, their children, their children's friends, their grandchildren's friends from accessing it by a very simple mechanism costing $1 to be able to lock these pill bottles. This is what I call the lockout effect. What do you think?
Having not studied the device or seen data center, I think I shouldn't comment on it.
Well, you can see it. It's right here, and it makes a lot of sense. So I'll just say that. By the way, CARA legislation also authorizes the Pregnant and Postpartum Women's Program, which creates a pilot grant program specifically for treatment for women who are pregnant or have young babies and struggle with addiction to deal with the issue, Dr. Ung, that you talked about. So that's in the CARA legislation, but you also talk about CAPTA, the Child Abuse Prevention and Treatment Act, and some of the concerns there. Can you tell us, because this is something, I've been at hospitals in Cincinnati and Cleveland and in Lima just in the last couple months, seeing some of these addicted babies, seeing the incredible compassionate care that they're getting as they take these babies literally through withdrawal. And one question I have asked some of these physicians and nurses and some of these amazing caregivers and some of the mothers is, what are the long-term impacts? And there's different answers I get, so I'd ask you as an expert, what research exists on the long-term effects of a child who is born with dependence on a substance like heroin or another opioid?
I'd be happy to follow up and give you this study. There was a meta-analysis that was done just a few years ago that looked at the whole, all of the body of research on the long-term effects of opioids. It's still a bit mixed, but as we still know that the alcohol and tobacco, alcohol in particular, have more neurodevelopmental effects than some of the other drugs. So it's hard to tease out when you look at what's happening for that child when they hit school. Was that also the fetal alcohol spectrum disorder, which was not manifested into full FAS, but had neurodevelopmental effects during that prenatal period? So it's still mixed, but as far as what I have been told, that going into the primary grades, that there are not effects that are teased out specific to opioids.
We're seeing a big increase in Ohio and other states on this neonatal abstinence syndrome, and I do hope we can get some better research on that. But in the meantime, of course, do everything we possibly can to prevention and treatment to avoid those babies becoming addicted in the first place. Thank you very much. Thank you, Mr. Chairman.